Hi. Well, Dr. Paez talked about CRPS, which I'm not sure that you guys remember what it means, but it means complex regional pain syndrome. And as he said, the nomenclature did evolve. It was initially reflex sympathetic dystrophy, when we believed that the sympathetic component played a major role in the diagnosis or in the pathophysiology. Then they came into consensus that that is not really true in all the cases, and the nomenclature was changed to complex regional pain syndrome. I personally believe that it will change again. It will have to, because it is not regional anymore. It can start regional, but it will eventually, in definitely a decent number of patients, become a whole body disease, a whole body disease. And it will spread to all limbs and the whole body and the face and the hair and everywhere. That's why it is more of a central sensitization syndrome. If we look at it this way, that's probably the proper diagnosis or the proper pathophysiology. So again, quickly through the Budapest criteria, I know he mentioned it before. The main thing is at least one sign in 2 of the following 4 categories and 1 symptom in 3 of the following 4 categories. The sensory, we're talking about hyperalgesia, which is more pain to pinprick, and hyperpathia, as well as allodynia. Allodynia is pain sensation with light stimulation or light touch, and that can be also due to light pressure. Then we have vasomotor, which is temperature changes and color changes, as well as asymmetry between the limbs. That may be difficult with whole body CRPS. The third is pseudomotor and edema, which is basically change in sweating as well as edema or swelling. Then we have trophic changes as well as motor changes, motor with spasm, dystonia, cramps, tremors, as well as the trophic changes with skin, as you saw in the picture, become shiny, loss of hair, as well as hair growth changes. CRPS treatment with IV ketamine. The FDA approved ketamine for anesthesia, but it is used off-label for CRPS. It is actually the strongest NMDA receptor blocker or antagonist. It has also some effect on the opiate receptors as well. There's lots of studies that have proven the efficacy of IV ketamine for the treatment of CRPS by lots of researchers and university. It's also present on the NIH website as a recommended treatment for CRPS. First treatment was actually used in 2002. There are several studies and research papers that showed the success of IV ketamine for CRPS. We have Sichtermans. He studied 30 patients with an average 63% pain reduction, and he looked for patients over 12 weeks. His dose was around about 0.35 milligram per kilo per hour and used 4 hours for about 5 to 10 days. And he found that very minimal psychomimetic effects like hallucinations as well as drowsiness. Schwartzman, who's the guru for CRPS as well as IV ketamine, probably most of the researchers followed his protocol initially, has studied 9 patients with average 27% pain relief, and this was a double-blind placebo-controlled study, prospective study as well. Correll did study 33 patients. He got 76% immediate pain reduction and 18% partial pain reduction and 2% no pain relief. And he followed patients for 3 months as well. So it was a retrospective study. Now, most recently, Zhao did a systematic review and meta-analysis of all the research and studies so far. And he included 15 studies in his research with data from 258 patients, all studies from 2002 till 2015. The mean treatment duration was about 8.4 days and ranging from 1 to 40 days. Meta-analysis showed that ketamine treatment was very effective and led to an immediate pain relief in about 69% of patients. And the pain relief, the relief was 69%. The pain relief at 3 months was 58%, which is still very effective comparing to the fact that we had nothing in the past. So the summary, ketamine infusion can provide clinically effective pain relief for short term, less than 3 months. So mechanisms of ketamine in the CRPS. In order to understand the mechanism of ketamine CRPS, we have to understand what's the CRPS pathophysiology. And we can talk about it for hours, and there are lots of papers about that. But I'll try to simplify it as much as I can. So when patients get injured, we have a constant barrage of pain signals that's hammering the brain. In some patients, we don't know why, whether genetic predisposition, whether anything else, we're not really sure why. But some patients, not others, their brain receptors will get inflamed, will get irritated. Certain receptors called NMDA receptors. When they get irritated, they release certain chemicals called glutamate. Glutamate, in turn, goes and causes inflammation of certain cells in the brain that we always used to think that they're really dormant and non-functioning, called glial cells. So the glial cells get inflamed, and glial cells, in turn, will produce other chemicals called cytokines. Cytokines will go all over the body. Cytokines cause small fiber neuropathy. And that is actually one of the main pathophysiology of CRPS, is that it causes small fiber neuropathy. Now, this small fibers go and supply the skin, and it supplies the autonomic nervous system. So when it supplies the skin, it causes pain, and supplies the autonomic nervous system. It goes to the blood vessels. They're supplied by the autonomic nerve fibers. That's why you get the color changes and the temperature changes, because they go crazy. They vasodilate, they vasoconstrict. So also Dr. Miguel and Dr. Paez talked about POTS, postural orthostatic tachycardia syndrome. That's also a result of the disturbance of the autonomic fibers, because they're small fibers. So it's nothing but a manifestation of small fiber neuropathy. Also gastroparesis, which is the GI. All the GI, the intestine, all supplied by the autonomic fibers. And those gets affected, they're small fiber, and patient may develop gastroparesis. So as you see, all of these manifestations are a result of the small fiber neuropathy. So what ketamine does, ketamine blocks the NMDA receptors. There are several other mechanisms for ketamine that it's really beyond the scope of this lecture. But just to simplify it, it blocks the NMDA receptor, blocks the release of glutamine, blocks or reduces the inflammation of the glial cells. And that will reduce the release of the cytokines, which are really toxic to the small fibers. So in turn, it will reduce the small fiber neuropathy. So basically, when we do the infusion of the ketamine, we're trying to reduce the inflammation of the brain. Ketamine is the most potent anti-inflammatory to the brain. So it reduces the inflammation, reduces the cytokine release, gives a break for the small fibers to regenerate. And that's why even sometimes patients may get an immediate relief with the ketamine. Some may not get as much, but may develop some relief a week later, 2 weeks later. And a lot of patients, we tell them, don't be disappointed if the first week you're not any better, because it may appear later when there's enough time for the regeneration of the nerve fibers. It is not an immediate effect. Ketamine is not working like opiate. It's not like you're taking ketamine as a pain medication. The difference, opiate immediately relieves your pain. Ketamine works on the pathophysiology of the disease itself. It reduces the inflammation of the glial cells, and it helps the pathophysiology of the disease. It's the only medications that can do that. There are others, medication that works on the NMDA receptor, but they're much, much weaker. So my protocol I use, and so far, I just want you to understand that there is no specific consensus on the specific protocol. There's no specific doses. It is all over the place. Every doctor is using his own cocktail or his own protocols. And no, I'm not claiming that mine is the best, or Dr. Silverman or Dr. Paez. Every doctor just probably with his experience, have found the cocktail that works for him. I have performed over 8,000 to 9,000 infusions with at least 12 to 14 infusions per day, probably one of the largest. And a lot of the patients we get have already done ketamine, have already diagnosed for several years. We rarely get, recent diagnosed patients. But anyway, my protocol is 5 to 10 days infusion, 4 hours every day, no weekends. First day, use 1 milligram per kilo per hour. Second day, 2 milligram per kilo per hour. Third day, 3 milligram per kilo per hour for 4 hours. Exact dose varies. A lot of patients will use much less than that. And on extreme rare occasion, I've used more than that. During the infusions, I don't rely only on the chemical effect of the ketamine. During the infusion, those patients already have atrophied muscle like you've seen in the pictures. We use physical therapy, we use electrical stimulation, even though a lot of the doctors or some of the advice is to avoid electrical stimulation because of the pain. But we take advantage that patients already getting ketamine. So we use those muscles because otherwise patients cannot use those hands. You've seen the picture. You ask them to go to therapy, they cannot do therapy. It's very painful. So during the infusion, they are under a significant amount of pain relief. We use electrical stimulation. Our patients will be all wired up, especially with the whole body. All electric stimulation, the upper arms and the legs, and have it all fired up. As well as we get physical therapy to do mobilization under ketamine. Because a lot of those patients have very stiff joints. They have developed some calcification, tendinosis. Those joints are extremely stiff. And we were able to gain a significant improvement with the mobility of the joint as well as function with that. After the initial treatment, we do 1 to 2 days booster every 2 weeks twice, 1 to 2 days booster every month twice, and then 1 to 2 days every 1 to 6 months or as needed basis. This is a protocol. The original I took originally that protocol from Dr. Schwarzman. And as far as the protocol itself, that's the exact protocol that he was using, but it was a much lesser doses. He was using about between 0.35 to 0.5 milligram per kilo per hour. But we had a lot of patients after he stopped the program, a lot of his patients were not responding. Management of the side effects, of course, with higher doses, there is higher side effects. So we get anxiety, hallucinations, we use benzos for that during the infusions, Valium, Versed. Nausea, we use Phenergan, Zofran. Headaches, we can use some Toradol and some lidocaine. Again, the goal is to maximize therapeutic effects with minimal side effects. I also, a lot of time, will combine lidocaine, which by itself, lots of research that showed benefit for CRPS patients. I will also combine magnesium, which also has an MDA effect as well, plus it helps relax the muscles. So I found that combination works really good when you mix that with the electrical stimulation and physical therapy. The goal is not pain relief, the goal is pain relief and function. And if you cannot get the function, pain relief, that still is not satisfactory to the patients. Now, opioids help reduce the severe mechanical pain, but as I said, it does nothing to treat the underlying pathology, especially with CRPS. So they have very limited benefit for the neuropathic pain. In addition, the addictive potential, like Dr. Silverman said, and the side effects of long-term use. Also, the problem with opioid for specifically CRPS is that they cause opioid-induced hyperalgesia. And that's basically because opioid cause inflammation of the glial cells. Again, that's the same problem that causes cytokine release, causes central sensitization, and it basically worsens the condition. Patients actually on opiate, CRPS patients or fibromyalgia patients who are on opiate, they stop opiates, and sometimes the pain improves. So ketamine has helped eliminate the use of opiate in CRPS patients, and there's evidence that actually I have used it a few times to detoxify patients from opiate as well. Now, if we compare clinical outcome, We reviewed, at least this was just a random 25 patient sample that we used. We had 89% reduction in pain in our study by using the higher dose infusion. And Dr. Schwarzman using 0.35 milligram per kilo per hour, it was 27%. Dr. Goldberg, 31%. He used 0.33 milligram per kilo per hour. The dose of ketamine really varies, as I said, and there is no specific consensus about it. It ranges from 0.3 to even less, and it can go all the way to 5 to 7 milligram per kilo per hour, like what they use in Germany and Mexico, which is not approved here, with the ketamine coma, which I'm sure maybe some of you have heard about it. Patients with CRPS, they'll travel, they'll go everywhere. We get patients from all over. We get patients from China, Taiwan, Europe. Patients will travel all over for CRPS because the pain is intense and disability is intense. So they will go to Germany, Mexico. I get a lot of patients who already had the ketamine coma, and it did help them. It did work for them. And those patients definitely have failed the lower dose infusion. Now, those patients, after we're done with the initial infusion protocol, we have to maintain them on boosters because it will come back. That is not going away. There is no cure for CRPS. Extremely rare cases. Now, as far as the blocks, I mean, it has some role, but if you now understand that it is a central sensitization syndrome, you can really understand why, Dr. Pez was talking about the ineffectiveness of those blocks. I find those blocks helps great if you catch the patients very, very early. And I had the opportunity to see some patients extremely early who were already my patients, and I can see them, developing CRPS from a trauma. So because they were my patients, I was able to diagnose it much faster within a month and treat it very aggressively. And so I did stellate ganglion blocks, sympathetic blocks, and when I did the blocks, I gave them ketamine with the blocks. Instead of giving them a sedation Versed, I gave them Versed and ketamine. That improved the potency of the block, and I got much better result, and I started ketamine immediately. Now, in the past, we used to say ketamine infusion is a last resort. That doesn't hold truth anymore. This is some case study. That's a patient who was my patient, came in from Colorado. And as you see, this is her arm when she came in. Very tight, very dystonic, very limited movement, depressed, totally disabled. And this was after 10 days of ketamine. The response is drastic. There is no block, there is no stimulator, there is not any other modality that will outperform ketamine in that response. We do spinal cord stimulator, but we found that 3-4 years later, a lot of patients want them removed. And by the time you get the authorization for the trial, by the time you get the authorization from the permanent, you're allowing time for the CRPS to spread, and you're making the patient resistant to treatment. So whenever I see the patients, I do exactly the same thing that Dr. Paez said, which is tell them, I believe you have CRPS, go Google it, look it up. This is the treatment. Blocks, medication, therapy, stimulator, ketamine, and come back. They come back and they do their own research. They come back and says, no, a lot of patients were saying stimulator, is not giving me they were not giving long-term relief, they had probably problems with it. I want ketamine now. So I let them actually make the decision instead of me trying to convince them. This patient responded very good. This is another patient that, very young patient, who was also totally disabled. She was getting those cramps and severe spasms all over her body. And this is her actually videotaping that, or her husband did videotape her. She became totally disabled, was not able to work at all, was completely dysfunctional, while she was having a very good job and was very productive. After 10-day ketamine infusion, she was almost a normal person. Till now, she still gets booster doses every 2 to 3 months, gets a couple of days, and she's already working. She returned to work full time. Few other patients. Diane, diagnosed CRPS 2010. She had work-related injury, severe pain, 9/10, hypersensitivity, completely disabled for 5 years. After ketamine treatment, pain went way down, sensitivity down. She was able to return to work full-time in a retail store. I gave her infusions every about 6 to 8 months. She gets 3 days every 6 to 8 months. After a while, every patient knows how many days they need, how many days works the best for them, and how often. Susan was an ICU nurse, diagnosed with CRPS 2011, pain 10 out of 10, became totally disabled. After ketamine treatment, her pain went down to 2. She went back and she did PhD, and now she's teaching nursing. Brandy, diagnosed CRPS 2014, pain 7/10. She also had severe intractable migraine, which I found ketamine works great for migraine as well. Even we had patients with hemiplegic migraines that worked great for them. After ketamine treatment, reduced all the way down 2 or 3, was able to return back to work. Andrew came in after a back surgery. The doctor nicked the L5 nerve root. Patient had severe unrelenting pain, weakness, developed CRPS immediately after the surgery. Had tried spinal cord stimulator somewhere else, and it failed. The trial failed. He came in. We did the ketamine infusion treatments. Now he's working as a contractor in the field, and he's working full time, and he gets treatment every about 2 to 3 months. So a lot of these patients definitely needs boosters, definitely need a very aggressive treatment at the beginning. How many days initially? And I had this with some of the case managers. It really depends on the case. You cannot say 10 days, you cannot say 5 days. I mean, I had patients who, she was on a wheelchair for 5 years. She had a whole body CRPS. She could not move her arms. Only what she could do like this, and legs the same thing. I give her 10 days, did nothing. I give her 6 weeks. Her pain reduced to like from 10 to 8 or 9. I had her put a port. She came back from Buffalo, and we did almost 3 months of IV ketamine infusions. The first 6 weeks were 8 hours every day with intense physical therapy, intense electrical stimulations. We just were insisting that we're going to make her better, and she was able to walk. She was able to walk with a walker after 5 years being on a wheelchair. So the answer to how many infusions is very difficult. Whatever infusions we need to do to get this patient back to life, because this patient has no life. And when we said, I think Dr. De La Garza said about the patient that this is the worst case he's seen. Well, the worst case I've seen are the one who committed suicide, because suicide rate is very high, extremely high among CRPS patients. So when you think about denying ketamine or taking too much time at the beginning trying to figure out, is it CRPS or no? I mean, right now, I urge every doctor to get an infrared camera. It's very simple. In the past, when I did my fellowship, we used to get the thermography machine, fancy test, take a long time, cost. Thermography camera, it's very simple. You can diagnose the asymmetry in the temperature immediately in 1 second and document it and move the case. Get ketamine immediately. Get therapy with the ketamine. If you don't do that immediately, you're going to pay a very, very high price, because that patient will not respond to the treatment later on. It will take you a longer time, and the response will be much less than you get it at the beginning. As I said, so it's an effective modality. Recommend to combine therapy with the ketamine treatment. Yes, all patients will come in and they said therapy failed. Of course it will fail. They cannot move. If they move, it will hurt. It's not that they are malingering. It's not that they are lazy to exercise. They just can't. The earlier ketamine is used for treatment, the better. I will do ketamine as a first line. As I said, in the past, it used to be, last line is the ketamine. Now it's a first line, because that's the only treatment that addresses the pathophysiology of the disease. Everything else is just peripheral. Sympathetic blocks, peripheral. Stimulator, peripheral. Nothing is addressing the pathophysiology of the glial cell inflammation, small fiber neuropathy, except ketamine. And a lot of time, as a maintenance, in between the infusion, I will put patients on ketamine troches, put them on oral ketamine, sustained release. Again, unfortunately, all of these are compound medication that we have to get workers' comp to approve because they're not your regular typical drug. Unfortunately, there is no drug approved for CRPS till now, none. And bisphosphonates, neridronates, I mean, that's only for acute phase. That's only for initial case. I've used bisphosphonates before. It's useless later on. Unless you diagnose the patient very early, it has very minimal effect later on in the disease, and most of the patients we see is, a late stage. So as I said, early, use the ketamine as soon as you diagnose CRPS. The one important thing that a lot of doctors, or what I call them CRPS guru will say is, if you think it's CRPS, treat it as a CRPS. If it does not fit the Budapest criteria, we made those criteria just to make it easy for us. That's not a law. Those are just criteria to help. If you think it's CRPS because you see sensitivity, you see swelling, but you don't see a couple of other criteria, if you doubt it is CRPS, treat it as a CRPS. Be aggressive with it. You can be wrong, that's no problem, but if you're right and you succeeded to help these patients early, that's a huge advantage, and it's not a problem if patient didn't have CRPS. Most likely it's atypical CRPS. It's some type of neuropathy. They're all related, central sensitization. It does not have to fit 100% the criteria. So again, ketamine is directed towards central sensitization. That's the main focus of our treatment. Currently, no drugs, available for that. And with the ketamine troches and the ketamine sustained release, I use also dextromethorphan. It's a cough medication that has an MDA effect that actually several studies have been using it actually with opiates, to reduce the opioid-induced hyperalgesia and potentiate the effect of opioid and reduce the tolerance. And I think everyone probably taking opiates should take a little bit of dextromethorphan. Also, a very important medication for CRPS is LDN, low-dose naltrexone. Low-dose naltrexone, about 2 to 4.5 milligram, usually taken after 9 p.m. It's opposite of opiates. So it blocks the opiate receptors in the brain. The brain senses there is no opiates in the body, start releasing its own endorphins. So it helps with the pain. Plus, it's a good anti-inflammatory to the glial cells as well. Right now, if you have pain, you can go to the ER. You have heart attack, they give you medication. You have stroke, they give you medication. But if you're suicidal, they have nothing to give you. So I believe ketamine is a major breakthrough for depression and suicidal ideation, absolutely. And we found that when we did patients for, CRPS and fibromyalgia and a lot of other conditions, that the depression significantly improved. Yes?
I have a question for you too. I know this is focused on CRPS, but my question is, what other conditions, such as back-related, chronic back pain, degenerative disc disease, the things we see a lot of, what have you found the ketamine infusions effective?
Yeah. Ketamine is very effective in a lot of neuropathic pain conditions, but unfortunately not indicated for mechanical pain. So patient with degenerative disc disease, herniated disc, it is not effective unless the herniated disc causes significant neuropathy and nerve injury and some type of CRPS-like condition, then you can use it, but it's not for joint pain, not for back pain. It's used for a lot of neurodegenerative condition, used for CRPS. Fibromyalgia is now also considered this type of small fiber neuropathy, and a lot of patients may get post-traumatic fibromyalgia from injury as well. We can use it for a lot of other conditions not related to workers' comp. Again, like depression, which again can be workers' comp. I've used it for MS, I've used it for ALS, I've used it for Parkinson's disease, I've used it for neuroleptic malignant syndrome, I've used it for CTE, chronic traumatic encephalopathy, used it for a lot of other conditions, inclusion body myositis. I got patients who are on a wheelchair and was able to stand and walk. So anything that is neurodegenerative involves brain inflammation, I think is very effective. Hopefully, I think in the future for Alzheimer's as well.
Yes.
Where are you doing these infusions? Is it in a hospital or outpatient? And what kind of success do you have with getting insurance companies other than workers' comp to pay for this?
I do it as outpatient. Again, you know, as just Dr. Silverman was asking, you know, you have to be level 2. I mean, definitely patient has to have all the monitoring available. And I actually take insurances. Again, insurance, sometimes they pay, sometimes they don't, sometimes they pay you less than your cost. But I mean, you just do it. If you break even, you know, we're okay. I think that's the problem of ketamine. Actually, you just hit on the actual problem, you know, of ketamine, is that most of the doctors will do it cash just because the reimbursement is very bad. But unfortunately, all those patients, you know, have no money.
There's not a lot of facilities around that are offering this in the state. I mean, that's an issue as far as the incidence of CRPS, which is very limited. True CRPS, I mean, it's promising, but I mean, some of your numbers or your statistics are interesting because, like the AMPM and the American Society of Regional Anesthesia, they just published a consensus statement in July about low-dose ketamine at 0.35 milligrams per kilogram, and yours are much higher. So I'm curious as to you know why the AMPM and the American Society of Anesthesia published this consensus, which is way lower than what your numbers are. Any thoughts on that?
Yeah, that's exactly, that's what Schwartzman started, and unfortunately, you know, we are mom and pop shop. I mean, we're solo practitioners. Dr. Schwartzman started this, and then he ended his program, probably because, and you will find very few hospitals doing that because of funding, you know, and reimbursement. So I inherited a lot of Schwartzman patients, and 90% of them, the dose he was giving was ineffective. It's as simple as that, and again, that's why we have lots of patients, because number one, we take insurance, number two, we use higher dose that is effective. Those patients need higher doses. You know, it just, and you may start lower, but if it's not effective, you have to be able to go higher. I mean, we're anesthesiologists. I mean, you know, you just do whatever you need to do, you know. But yes, those doses are very low. They're not going to be effective.
Question
Yes.
back.
Is there any research being done where alpha-lipoic acid may help nerve pain, where it could be perhaps research like the ketamine working, that maybe it would, because of less side effects? Are any of these specialists aware of any research?
Yes, I mean, I use alpha-lipoic acid. I give patients usually a list of a few natural products, you know, magnesium, vitamin C, alpha-lipoic acid, turmeric, and even luteolin and forskolin. Now, all those natural products, they work, they're anti-inflammatory to the glial cells. Now, ALA, definitely, there's lots, actually few studies, you know, in Europe, in Germany, about ALA for neuropathy, and they did a study on diabetic neuropathy. So definitely ALA is a good natural product. Now, is it effective? I mean, it helps some, but I mean, it's definitely nothing to comparing to ketamine, but it's a reasonable adjuvant product. And I use also PEA, which is palmitoyl-ethanolamide, which actually works also, I believe, on the endocannabinoid receptors and does provide some good relief with CRPS and fibromyalgia patients.